Have you ever felt lost in the medical system? Ever felt like there's a map and no one knows how to read it? You're not alone. And that's because the medical system is extremely complicated. By the end of this talk, I will have walked through the limits and the strengths of each phase of the medical system from the clinic all the way to the ICU. And hopefully I'll give you some tips on how you can navigate that and make sure that you're going to the destination that you're striving for. But before I get into it, I'd like to introduce somebody. This is Kay Montgomery. She's an 87-year-old woman. She's been living independently since her husband died 15 years ago. She's been managing her finances. She's been going to her grandkids' birthdays. She's been part of her church. She's been doing everything very well. But recently, she started having some hard time breathing. So she decided that she needed to go to her doctor. So she went to her physician, and this is my clinic, not hers. And she talked to Dr. Smith, a hypothetical physician, and started telling her about his problems. Now, Dr. Smith in his clinic has been seeing Kay for the last 20 years. He knows all the medications she's been on. He knows what surgeries she's had. He's had lots of long conversations to help her figure out how to take care of herself. Now, in the clinic, the purpose is extension of life. The purpose is controlling blood pressure and diabetes and cholesterol, working on pieces that have the best outcome long term. It's not great for the short-term emergencies. Now, a stubbed toe, a small broken bone, something like that, primary care is excellent. They may or may not have access to imaging, or they may have to order it. Labs don't come back the same day. Oftentimes, to get a stat lab is 6 hours. So if there's an emergency that needs labs or needs imaging, some of that can be done in your primary care doc, but a lot of it's going to need to be referred to either an urgent care or an emergency room. Well, when Dr. Smith was actually evaluating Kay, he recognized that she was short of breath and she was having a really hard time breathing. So he said you would really benefit from going to the emergency room. So Kay went to the emergency room. And at the emergency room, they evaluated her. They saw her quickly. They were able to get vitals and start interventions right away. They recognized she was having a hard time breathing. They gave her treatments for her breathing. And they were able to actually get her into a spot where she was stable to go home. The emergency room is designed specifically to handle urgent and emergent situations. They're able to give medications right away and see immediate responses. They're also able to do treatments that you aren't able to do in your clinic. They're able to get labs within 30 minutes to an hour. They can even get imaging like a CT scan or an MRI, sometimes same day or less than 30 minutes from when someone shows up. So the benefits of an emergency room is that immediate life-saving interventions that can help somebody. The other part is being a gatekeeper for the hospital, and we'll talk about that in a minute. But Kay was fortunate enough, and she was able to go back to her home and doing pretty well. But the emergency room said, you should follow up with your doctor. And that's what she did. She went back to Dr. Smith, and he was able to see her labs that were done, but he didn't see any of the documentation. One of the challenges in the medical system is actually communicating between these different phases of medicine. Fortunately for him, Kay brought her discharge summary, and they were able to see what medication she was discharged on and what pieces need to be followed up on. There were a number of labs that he saw that were actually really concerning. She had some issues that looked like there was some strain on her heart. She had some issues that maybe there was an issue with her breathing and her kidneys. I call this the IST disease, when they started getting all the specialists involved. So Dr. Smith said she was a little confused and referred her to the neurologist, the cardiologist, the nephrologist, gastroenterologist, ophthalmologist, hematologist, pulmonologist. So all of these doctors did a great job evaluating Kay. Now, their strengths is that they're able to focus on one organ system. They're experts in that organ. The cardiologist knows the heart inside and out. And he started some medications specifically to help her heart because of the strain they saw in the hospital. And then she went to see her nephrologist, and the nephrologist was concerned about her kidneys. Now, the kidneys didn't like the meds the cardiologist started her on, so the nephrologist said, let's change those meds to something else. And then they put her on a different medication. They saw the gastroenterologist, and the gastroenterologist was worried about her bleeding, so he actually changed her meds again. Then the neurologist put him on a different medication. You can see how this can compound, where people may not be communicating between each other, and it's one of the most challenging pieces of medicine. And like I said, these people are all experts, and they're all trying to do the best to help Kay get over this condition, but at the same time, they may not be fully communicating with each other. Fortunately, there are things you can do to help with that, and I'm going to talk about that a little bit later on how to minimize that risk. Unfortunately for Kay, these conditions started spiraling, and with all the different cooks in the kitchen, she actually started having some significant complications and ended her back up in the emergency room. At this time, it looked like Kay was in heart failure, and she was also having an exacerbation of her asthma. So she was admitted to the hospital. Earlier I'd said that the emergency room is a spot where it treats emergent conditions and also is the gatekeeper for inpatient medicine. Now, inpatient medicine is going to be where you're going to have interventions that are going to be monitored day to day. The doctor will usually round in the morning and make orders and check labs throughout the day with a plan to change therapies the next day. The vitals are often every 4 hours. Sometimes people can sleep, some people can't, but oftentimes this is actually scheduled for the hospital and not for the patient. It's not the most comfortable place to be, but it does allow us to make interventions quickly and see what's going on. Unfortunately for Kay, she was in the hospital and she was on the inpatient setting, but she was deteriorating. They decided to transfer her to the emergency care unit. She was having a hard time breathing, as you can see, and she was having a lot of problems. So the intensive care unit is now making interventions possibly every 5 minutes, possibly every hour. Oftentimes it's a nurse to every patient, be able to monitor and see how she's doing and make changes. Unfortunately for Kay, as her condition progressed, they decided that it was time to actually withdraw care. And Kay's family was able to be there, and they said, we're going to transition you to hospice. And she was on a hospice for maybe an hour, which is a disservice to hospice, and we'll talk more about that. But really, truly, it was comfort care to help keep her comfortable in her last moments while she was surrounded by family. Hospice, on the other hand, now hospice is specifically a program put together by the government to support people in the last phases of life. It requires an expectation of 6 months or less to live, which Kay obviously met. However, most people, about 60% of people, will actually pass in that first week to 3 weeks when they join hospice, but several of them, many of them, will actually pass much longer than that. And that's the goal of hospice. The goal is to help somebody be comfortable in that last phase of their life, and also to be able to help them to achieve their goals and what they're trying to do. They a lot of times will treat at home, and they'll be able to help keep somebody comfortable with their family in their house, or in a nursing home, whatever works best for that family. Now, the next phase of this piece, though, with all the complications Kay was having, would have been palliative care. Palliative care is a little bit different. So when somebody has a complex medical condition or numerous conditions or lots of medications, they need to focus on how they can make those better or how they can help control them or understand them. Palliative care really excels in this phase. What palliative care does is it allows somebody to actually meet, talk to a provider, and understand what the progression of their diseases are, and also what medications may or may not be in goal with their long-term plan. So they will often be referred to by their primary care provider, and then they're able to make those recommendations, send it back to the primary care provider, and be able to help them understand what to expect as their diseases progress. A lot of times this is done when somebody has a terminal illness, but that's not always necessary. Sometimes the better time to do this is when somebody is starting to struggle with all the different conditions, so they can really get a handle on what their goals are and what each therapy is doing. Now, Kay Montgomery was actually my grandmother, and the reason I'm doing this talk is I felt like the hospital actually did her a little bit of a disservice because they weren't able to give her that opportunity to have her goals met. And I wish they had engaged hospice earlier than when she had an hour left to live. And while hospice can be special in that moment and help her be with her family when she passed, I think that this could have been something they could have done sooner and possibly been even at home. But this has given me a passion to talk about this with you, and I really appreciate you talking to me. There's a couple things that I really want to hit on that I think could have helped Kay out, or KK, and I want to talk about those so that you can be prepared when these things happen to you. Now, being prepared is probably the most important thing that you can do to minimize the confusion in medicine. Having a document that has all of your medications on it, that's updated every time there's a change, that has recent imaging or recent labs on it, that information can be vital for every time somebody's in the hospital, every time someone goes to a new doctor, every time someone's prescribing a new medication. It can really cut down those medication errors that could have led to it. I would like to empower you to do that and have that opportunity. Now, if you're not in a phase where this is an issue for you, but you may have a parent that somebody or someone that you're concerned about, you could be present there too and help facilitate that as well. If somebody's having a hard time remembering the details, being present in physician encounters or being present in the hospital can be immeasurably valuable in those settings. Now, with technology, you could even FaceTime to be present, And that can be a really useful technique so that you're able to be engaged in your family member's care as well. Thank you so much for your time. And if you have any questions, please check out our website. Have a great day.